I'm aware that it's quite cold in here, and the midwives here will know that that really reduces your oxytocin levels. So do I have to press this all the time? Can you hear me? Yeah, okay, I don't have to press it all the time. So if you feel cold or at some point and you really need to move around, just put your hand up and we can take a few minutes to pause to get your oxytocin levels going. I'm going to be talking about humanization of birth, which is a really big subject. And I've got a lot of slides, and some of them I'll go through very quickly. But the main thing about this lecture is to have you think. And this lecture is applicable to anybody, because of course the way we look after women when they give birth, the way we care for babies when they're born, is of huge importance to each one of us, and every one of us has been born. So this is of relevance to everybody in the world. And some of it will be quite technical, but some of it is about more kind of general ideas around humanization. And I'd better be careful not to get carried away, because at the moment we're going through huge democratic and social upheaval, aren't we, with Trump in the presidency, right-wing presidents being elected around the world, and the Brexit and what it's doing to us as a society. And so humanization actually is a concept that has relevance to any field of human life. And I'm going to be referring to the research around continuity of carer and how we might move that forward, because it's of particular importance to maternity services at the moment. So the world is changing. This is a women's march in London when Trump was elected. How many years ago? It seems like a lifetime away, something that we thought would never happen. And this is me with my daughter Anna and Lina Duncan, who is now a doula. She was a midwife in Mumbai for some time. And we were standing, do you know Trafalgar Square? We were actually standing on the wall of the fountain. Now, I used to jump up on that wall really easily when I was sort of 18, 19, 20, 21. And I thought nothing to it. We managed to get into the middle of a very, very packed Trafalgar Square, moving through all of the crowds, and we had taken cake because we were midwives and we wanted to give everybody cake like they do in Call the Midwife. People loved us. And we managed to get to the fountain, and I thought, oh, I'll get onto the wall of the fountain. Well, I got up there, nearly pushed a few people in who were helping me up. But I got up there and we had the Royal College of Midwives flags, and we were leading a chant. What do we want? Women's rights. When do we want them? Now. And we had a huge following with us because my daughter's a bit of an actress. But anyway, the reason I show this slide is because the world is changing very, very fast. There is huge democratic and social upheaval going on around the whole world, and it will impact on birth, it will impact on us as midwives, as nurses, as sociologists. It's representative of an upheaval which I think is similar to a revolution at the time, and we don't know how it will evolve. And my belief is the way we look after babies when they're being born, the way that we look after women when they're giving birth to the babies, the way we look after the family will make a huge impact on the quality of life and the quality of our communities. And we know that the course of childbirth is inextricably bound to the development of society. I found one of the best studies of medicalization of birth from sociologists in Slovenia. And I can't pronounce the names, but actually I've just been to Slovenia a little while ago to give a talk. I met the president of Slovenia. And the midwives there were absolutely delighted that I was using literature from Slovenia, because it's actually quite a small country, as you know. And I'll be talking about that at a moment. But the reason I show this picture is that the way we care for women when they give birth, the way we care for the babies, the way we care for the family, the way we care for our colleagues will cast ripples that go out into the world. And this is me. Do any of you know the Cottage of Robert Louis Stevenson? This is the Cottage of Robert Louis Stevenson. And I was a pupil midwife living with the community midwives in Colinton Mains in a little farmhouse in the middle of a council estate. And we were on call for home births, and we saw women in the community, and we saw women after they'd had their babies. And one beautiful May morning, the two sisters said, we're going to stop on our rounds and we're going to have a picnic outside of Robert Louis Stevenson's house. Can you imagine that now, having a picnic in the middle of your rounds? And so the two my other pupil and me and the two sister midwives had a picnic outside of Robert Louis Stevenson's cottage. But the reason I show this slide, and this is me, it's a cartoon that I drew for my parents, sent to them in a letter. And when my father died, I found the box of photographs, and this picture was in the box of photographs. And this is me in the hospital. You see my uniform, and the babies are in a trolley, and we would take them away from their mothers and take them out for breastfeeding every 4 hours. And probably you don't know this, but if you have 10 babies on a trolley, and you line them up behind each other, they fix onto the head of the baby in front of them. So babies will find something to suck. And so if you put the babies on their side, they would latch on to the head of the baby in front of them. But the serious message of this picture is I was learning about the factory system of care and the social model of care. It wasn't a golden age, but from that time, because I attended home births, I have this sense of peace when I go to a home birth. I have a kind of image of the way normal birth might be. And we were expected then to observe 10 normal births before we could attend what were called abnormal births. And in the hospital, we were called to a delivery by a flashing light. And so you would be on the postnatal ward and you needed to get another delivery. So the flashing light went and you ran down and you went into this room with a woman who's starting to push it you'd never met before, and you caught the baby because, you know, we needed to get our numbers of births. So it was very much a factory system. And here, if you can read it, I've got comments about my uniform, and I've got comments about the feeds waiting to be made up, because one of the things that we did as pupil midwives was make up the national dried milk. And we used the condensed milk, which was full of sugar, and we washed the babies in Pfizer Hex, which was later found to be associated with brain damage. So the babies would be sterilized. So you see here the emergence of this medicalized factory system alongside we were midwives on the district. So actually in life, I lived through this natural experiment. Well, I'm going to be talking about the shift from medicalization to humanization because, as we all know, we've gone through a stage of medicalization of care. And when I talk about medicalization, I'm not talking about medical care, because access to medical care is extremely important in whichever part of the world we live. But this is about over-medicalization, institutionalization of care. And it's not right, I think, to just think about the negative, what are the problems with medicalization. We have to think about how we resolve it, how we move on. And I've talked about the paper from Slovenia about medicalization of pregnancy and childbirth, the implications in Slovenia. And here are the authors of the paper. And they talk about the medicalization of birth being a process by which non-medical problems become defined as medical. And actually, if you think about childbirth in much of the resource-rich world, or the parts of the world in which they're middle income, you will find that birth is seen mainly as a medical event. And pregnancy and birth become the subject of the jurisdiction of medicine. And I would include in that midwives and midwifery, because we're actually a part of that jurisdiction of medicine. And normal phenomena become problematic and a new consumer market is created. We were talking at lunch about the gifts that are given to doctors. We think about the money that's put into marketing formula food, for example, and we think about private practice. And there are parts of the world in which in private practice the cesarean section rate is 80 to 90%. So this commercialization is a really important part of the process of medicalization. And medicalization can become social control, and it's deeply rooted in current and local cultures. And you have to recognize that the medical culture is very strong, and much of what we do in our care, midwives and doctors combined, is at the level of ritual. For example, putting everybody onto a fetal monitor is part of the ritual. And if you think about your day, there'll be a number of things that you do that are actually not evidence-based. They're at the level of ritual. And this social control can be very, very strong. So, for example, at the moment, every woman coming into the health services and maternity services has a lot of screening tests. And I'm not saying that these are wrong, but actually then there are debates about whether or not we want a society in which there are no people who have Down syndrome, and what is our attitude to congenital disabilities, for example. Also, the control of home birth. It's usually accepted that hospital is the best place to give birth rather than home. And despite the policy in the United Kingdom being to support women to choose where they give birth, the home birth rate is very, very low. But there is a tension in all of this because, of course, medical care is important. Technology saves lives. And so what we're looking for really is a balance in emerging from medicalization or institutionalization of birth. And if we think now, if we shift from medicalized birth to humanized birth, in the medicalized or industrialized model, we have depersonalized care. We have women going into fragmented care in which they don't know all of the people who are looking after them. They see many, many people, and we find extreme depersonalization of services. And on the other side, human rights and respectful care. Birth seen as a medical event, or the wider significance of birth being recognized. The mother and baby being seen as separate and being separated. And even although now we have approaches to make sure that there's skin-to-skin contact after birth, still the hospital routine is that after birth, you have to sort out the mother and baby to get them to the ward quickly. So actually this kind of separation of mother and baby and the separation of event is very deep in our culture. In humanized birth, there's a recognition of the importance of secure attachment. And normal physiological is deviant. And you haven't got such a big problem here in Scotland, but in England, from the summer 2 years ago, the headlines in many of the newspapers have been about normal birth as a cult, midwifery as a cult, normal birth being dangerous to the safety of mothers and babies. And so even in the United Kingdom, with our very, very strong policy, our very strong midwifery profession, we're beginning to see the emergence of normal birth being seen as deviant. And this is probably one of the most important things we have to deal with. And on the side of humanized care, evidence-based appropriate care, and focus on pathology and risk, and fear around the world is rising. Fear amongst women giving birth, amongst those looking after women is rising. It's well documented, talked about in the Lancet series on maternal health. To the humanized approach, which is about achieving optimal health and well-being. So rather than focusing on one outcome, which is avoiding death, which of course is very, very important, But it's much more than this. We're looking at a balance of things. It's not just one outcome, it's a number. And what we're aiming for is optimal health and well-being. And it sounds like a very narrow shift, but it's really a very important one. In medicalized care, we have high intervention rates. In humanized care, intervention when it's indicated. In medicalized care, focus on technology, care is fragmented. And in humanized care, we recognize the impact of relationship, both the relationship between the baby and the mother and parents, but also between midwives and doctors and women and their families. In many countries, midwifery was totally eradicated. In Australia, pretty much eradicated. In New Zealand, I think close to eradication. Canada, United States of America, midwifery was eradicated. There are many parts of Europe and in Brazil, there's been a complete eradication of midwifery or limitation of midwifery. And even here in the United Kingdom, we're debating at the moment whether or not our regulation allows us the autonomy that we should have to be effective practitioners. And then the humanized approach is scaling up, extending midwifery, but extending appropriate models of midwifery. And in the medicalized approach, a focus on acute care hospitals, and in the humanized, prevention and public health and community-based. So the humanized approach is a much wider one, and it's focused on the reduction of inequalities, for example, the provision of medical care, but also recognizing the significance of the event. So here, this was one of the first articles in the Times. Women will no longer be told that they should have babies without medical intervention. Do any of you remember these headlines starting? It was pretty worrying. I was on holiday at the time and lost much of my holiday. I got a letter published in the Times, but we thought that there was one article, we thought that would be the end, and with regularity we were seeing headlines being published, and they were all the same story, and they were often about poor care or poor systems of care, but actually midwives trying to achieve normal birth was always what was blamed on the poor experience or the poor outcome. And they've slowed down, but they haven't stopped. I think in Scotland you didn't get the same kind of impact that we had in England. So I just love to remind people that midwifery or midwife has a different meaning in every part of the world. Here in English it means that we're with the woman. That relationship which is on the same level as a woman working in her best interests. And in Iceland, the midwife is mother of the light. And it's been, the Icelandic people love linguistics, and it's been voted the most beautiful word in the Icelandic language twice. Last year it was voted the most beautiful word in the Icelandic language. And I like to think of it as enlightenment, because what we're trying to move towards now is enlightenment thinking about what we're doing. And this was given to me by Olafsdóttir, who was my PhD student and one of the leaders of the wonderful development of midwifery in Iceland. So I first became involved in the movement of humanization of birth in Brazil in the year 2000. And many of you who've done any kind of international work will know that Brazil was really the world center of high cesarean section rate. Women, a lot of women had a cesarean section, but those women who didn't have a cesarean section had very poor care. They could never take a family member into hospital with them when they went to give birth. There was no pain relief, there was no midwifery, and it was very, very dehumanized care. And Brazil has done a wonderful job of humanizing birth, and they've had a number of conferences that I've been to that have looked at this issue of humanization of birth and how we can move forward to humanize birth. And their government actually stepped in and said that by law obstetricians had to inform women of the risks of cesarean section. And in fact the cesarean section rate started to go down in Brazil. Now, with their new regime and their new president, who's actually very right-wing, we might see some changes. But I've been to Brazil 9 times. I've worked in clinical areas in humanized birth services because they're trying to regenerate midwifery. And the midwives there talk about doing a humanized birth. And they're really wonderful the way they've moved forward in changing birth from a very, very difficult situation. So the one in the International Journal of Gynecology and Obstetrics that was published in 2001, we described humanization as a process of communication and caring between people, leading to self-transformation and an understanding of the fundamental spirit of life and a sense of compassion for and unity with the universe, the spirit and nature, other people in the family, the community, the country and global society, and other people in future as well as past generations. This was a mixture of Brazilian, Japanese people, and some of us from different parts of the world. It included the wonderful Marsden Wagner and Robbie Davis Floyd was involved in this conference as well. So Marsden Wagner actually described humanization like this. And this is really important. He said, when we're working in the maternity services, it's as if we're goldfish in a bowl. We don't see the water that we're swimming in. We take it all for granted because the water is just there, you can't see it. And he says, he died a few years ago, he was an obstetrician who worked with the World Health Organization. Humanized birth puts a woman in the center and in control. It focuses on community-based primary maternity care with midwives, nurses and doctors working together in harmony as equals and has evidence-based services. Western, medicalized, high-tech maternity care under obstetric control usually dehumanizes, often leads to unnecessary, costly, dangerous, invasive obstetric interventions and should never be exported to developing countries. Midwives and planned out-of-hospital births are perfectly safe for low-risk births. And I led the creation of a definition of humanized birth for the International Confederation of Midwives a couple of years ago, and we described it like this: care that recognizes the significance of birth for individuals, family and society, that respects human rights of the woman to access high-quality, evidence-based care. Humanized care puts the woman at the center of care, recognizes that the mother and baby are inseparable. The woman and her baby and family are treated with dignity and respect, and the woman has the right to make decisions about her care. This decision-making process will be enhanced by a relationship of reciprocity with her midwife or midwives, and supported through the appropriate provision of high-quality information. And this definition was agreed by the Central European region of the International Confederation of Midwives and taken to the Triennial Congress last year and was accepted by ICM. So what's really exciting about the humanization of birth is that it's actually a mixture of human rights and science, and of course takes into account sociology, theology, a number of academic disciplines. And this introduction of human rights into birth has been, I think, really important to our development. And this is the book by Rebecca Schiller, wonderful book on human rights in birth. And she talks about the right to universal access to healthcare, because remember, in some parts of the world, women don't have access to a skilled birth attendant or systems of care. The right to high quality care, respectful care, dignity, autonomy, privacy and equality. And you see here the link to her book. And we also have from the White Ribbon Alliance, respectful maternity care, the universal rights of childbearing women. And this is really important because what has been found, and this is quite a recent realization or understanding, is that disrespectful care makes unsafe care. So to give you a very simple example, in some parts of the world where women could go to a hospital to give birth, they won't go because people are unkind and cruel to them, to the extent of slapping, of physical abuse, but also verbal abuse. And so disrespect and abuse in childbirth is a global problem. It occurs in low, medium, and high income countries. There are many anecdotal reports, little formal research, but we're developing a lot more now, and some midwives are doing some really good research. There's no normative standard for respectful care, and it's a violation of human rights. So what are those humanized approaches? This is Jessamy, who gave birth with a lovely midwife here in Dundee in the midwifery-led unit, and her mother Anna, who's a midwife. Well, let's look at some of the disparities of care. The Lancet series on maternal health, which was published in 2016, describes the gap between the group of countries with the highest level of maternal mortality and the group with the lowest, and that gap has doubled in size, so the inequalities are greater. And despite the increases in maternity care coverage in the past 25 years, an estimated quarter of pregnant women still do not access skilled care at birth. So we have to bear that in mind when we're thinking about humanized care. But this Lancet series, for the first time, described the two parallel problems in the world. One is too little care too late, lack of access to medical care, professional care around birth, too much too soon, over-intervention in birth. And I, with a number of my midwifery colleagues, have seen this as a developing problem. I've been aware of it for over 20 years. But at last we have some evidence about the problems, and we see differences between countries, but within countries. So, for example, there are very, very poor countries where women have little care at all, little professional care, a little access to skilled birth attendants, but other portions of the population have very, very high cesarean section rates. So too little too late is a lack of evidence-based guidelines, lack of equipment, inadequate numbers of skilled providers, women delivering alone, lack of emergency medical services and delayed referrals, and too much too soon, unnecessary cesarean section, routine induced or augmented labour, routine continuous electronic fetal monitoring, routine episiotomy, and routine antibiotics postpartum. And then recently, of course, just a few weeks ago, we had the publication of Optimizing Cesarean Section published by The Lancet. And what this series does is draw attention to the huge global epidemic in the increase in cesarean sections and the disparities. So we need cesarean section at a certain level, indicates that women who need it have access, and that is usually around 10 to 15%. But once cesarean section gets above that number, you see the problems of cesarean section emerging, but there isn't any increase in positive outcomes. So when we have cesarean section rates at above 15 or 20%, we actually don't see improvement in mortality and morbidity rates, but see more problems. And a number of midwives have been involved in this, and Jane Sandel led the second paper, which looks at the problems of cesarean section, both the short-term and the long-term effects of cesarean section on the health of women and children. And then the third paper is about interventions to reduce unnecessary cesarean section. Now, how many of you know about this publication? Few of you, because it's really worth reading. It's quite complex, but the third paper in particular shows you just how difficult it's going to be to reduce the cesarean section rate around the world. And my feeling is that we shouldn't go into a service and say we're going to reduce the rate. We should concentrate on giving women good, high quality care, and particularly high quality midwifery. and actually having women in midwifery-led care and giving birth at home will reduce the cesarean section rate. But this is about whole systems change, and it's well worth a read. And so Jane Sandel gave me this slide. Cesarean section is the most common surgery in many countries around the world. It can save mothers and babies' lives when complications occur, and it should be universally accessible. It's increased over the past 30 years without significant maternal or perinatal benefits. Cesarean section, for non-medical reasons, is a cause of concern because the procedure is associated with considerable short-term and long-term effects and healthcare costs. And this is the way that cesarean section has risen around the world. It's almost doubled in less than a generation, from 12% of all births in 2000 to 21% in 2015. And when you take into account, this includes countries in which there's a very, very minimal rate of cesarean section, less than 10%, you can see that the cesarean section rate in some countries is very high indeed. And I'm not going to go into this great detail now because we're running out of time before the brief break that we're going to take. But if you look at this map, you will see that the very, very deep purple are the high cesarean section rates. So North America, for example, is 32%. And the lower purple is a bit lower than that. To the lowest countries, West and Central Africa, 3%, 4.1%. So remember that the cesarean section rate probably needs to be about 10% in order to show that it's accessible to those women who need it. And what's interesting about it is if you look at Europe, the post-communist countries, the cesarean section rate went from a very low rate to a very high rate very quickly. And this, I think, is due to the commercialization of birth and cesarean section. So many of you will know this, but I'm not going to go into it now. But basically, there are a number of short-term and long-term problems associated with cesarean section for the mother and the baby. There are some benefits, such as less frequent incontinence and urogenital prolapse, which have been described. But I think that we can't say that we should offer women cesarean section in order to prevent these. And personally, not personally, it's based on ethics. We shouldn't be offering women cesarean section unless they have a medical or psychological indication for it. And this is really important because what has been found is that in countries where cesarean section is very, very high, often they don't know the gestational age of the pregnancy, and so babies are born prematurely. And infants born by cesarean section have different hormonal, physical, bacterial and medical exposures, and such as intrapartum antibiotics and neurotonics. And they're exposed to more short-term risks, such as altered immune development, allergy, atopy, asthma, and reduced diversity of the intestinal gut microbiome compared with those born vaginally. And emerging research has shown biological mechanisms that underlie the acute and chronic effects of cesarean section on child health and the long-term effects of cesarean section on children, including how these effects might be mitigated. And the World Health Organization, at the same time as the Lancet, published these recommendations on non-clinical interventions to reduce cesarean section. So when we talk about the humanization of birth, we're really widening our view. And what I like to think about is many of the sciences that we have on our radar screen. By the way, can you hear me when I wave my arms around like this? Many of the sciences that we have on our radar screen are some of the medical sciences, and some of the sciences that are really important are off our radar screen. So, for example, we're becoming aware of the microbiome and the impact of breastfeeding and being born on the microbiome. We're aware of the impact on the biology of the attachment between the mother and the baby, the growth of love between the mother and the baby. So we're becoming aware of sciences that are really important to us, but they're off the radar screen. This, by the way, is Kate, who gave birth to her baby in a little cottage outside of Chipping Norton, where I worked for several years, 7 years in the birth centre, on a very, very snowy day. And the midwives made it to her, although it was very snowy and icy. And this is the first birthday cake. So I'm going to stop for a few minutes to give us a few minutes break. But before we stop, I want to talk about this wonderful book called Towards the Humanization of Birth by Elizabeth Noonan, who is just returning to Australia from Ireland. She's been in Ireland for a few years. And she has really helped my thinking about the humanization of birth. And I'll talk about that for a little while after the break. Thank you very much indeed. Thank you. Good to see you all come back. I've realised I've got far too many slides. I put together a new presentation, and because I had 2 hours, of course, put in far too many slides. So I'm going to skip through some of them because I want to make kind of major points, really. But I was thinking about our discussion before we went for tea and what's different now. And I think we are going through a kind of paradigm shift in the way we think about things, and a lot of things are coming together that might be useful for us. I'm not going to say it's going to be easy, but I think we know what works and what helps to humanize birth. And what I'm going to do is actually go through some of the evidence I have about medicalization of care and the need to humanize birth, because I want to focus a little bit on the introduction and extension of continuity of carer, because I know that that's something that Susan asked for in particular. But first of all, I want to talk about this book by Liz Noonan. It was actually a study of the humanization of birth and epidurals in a hospital in Australia. And it's an extremely well-written, very thought-provoking book. And it's really good on describing the culture and the dominance of the medical view of things. For example, and when I talk about the medical view, I'm not talking about doctors, I'm talking about a kind of cultural approach. And for example, she gives a description and shows us the protocol for water birth and the protocol for epidural. And the epidural is discussed in a matter-of-fact way, and the risks aren't highlighted at all. And the water birth has a hugely bureaucratic approach to getting consent, and the risks are highlighted throughout. So she does a very good description through this study of epidural, of describing the different cultures of care. It's very, very well worth reading, and it's actually a beautiful piece of research. And she talks about the paradox of the institution, about the institutional surveillance that we think equals safety, and actually the institution often increases risk. And she has some lovely diagrams to show. So I love your policy, which is best start. And I think this question about how do we give the best start in life, what matters, is very, very important, because birth has become like a medical event, and we've forgotten that this is the start in life, and the way the woman feels about her experience, whether it's a positive experience or a negative experience, will have a huge impact on her as a mother and on the family. And we often interrupt the integrity of the family. We disturb the physiological basis of love and attachment. So thinking about this being the best start in life, and just so we don't only focus on the baby, because the baby and mother are together, they depend on each other. I like to think of this being the best start in life for the baby and the birth of the baby is the birth of the mother. So the woman becoming mother, this is the start of a different life for her. And then, of course, the best start for this newly formed family. And here's Jess, once again, getting beautiful midwifery care. And if we look at the wider world and we look at what impacts on the health of women, we can see that actually medical care in itself isn't enough. We need to think about social ecology, we need to think about ethics, about the organisation of care, the culture within communities. And if we look at what has the most impact on the outcomes and experience of birth, inequalities, ethnicity, geography, gender and violence, Indigenous women, migration, detention, we have the highest levels of migration since the war and possibly since we started keeping records. Warfare, humanitarian disasters, commercialization, health services, mental health, and medicalization. And if you think about our world, a lot of the women that we care for have migrated, they've been in detention, they have many of these factors have affected them. And in the United Kingdom, we have excellent work looking at maternal mortality and morbidity, and the recent publication of Embrace on the care of women from vulnerable groups is really important. And this is particularly important when we think about continuity of carer, because if we can only provide continuity of carer for a small proportion of a service, we should be thinking about providing it for vulnerable women. And Embrace actually gives a lot of information about the women who died, and basically vulnerable women form much of that group. Most women who died had multiple health problems or other vulnerabilities. And there is a higher death rate amongst Black and Asian women in deprived areas, older women, we talked about that earlier, and women born outside the UK have the same risk of dying in pregnancy. Domestic abuse, being known to social services, all have an association with death and morbidity. And I started to think about these big picture factors which impact on women's health when I was president. In the last few months, I wanted to make visits to vulnerable women who represented probably the most vulnerable women. And I went with Lina Duncan, whose picture you saw earlier, to Mumbai. And I visited women living on the railway tracks, families living on the railway tracks around Mumbai. And this was a really good representation of how we've medicalized birth, but actually don't think about the social or political factors that we should be thinking about. And so these women were being called for ultrasound scans, but they were living in probably the most impoverished circumstances you could think about. And we actually, the women who were pregnant at the time, we gave them their money for ultrasound scans because they're expected to go for ultrasound scans, but it takes a huge proportion of their income. So birth was still being seen in these medical terms. And I have to tell you, to go into hospital to have a baby in India is like torture. I couldn't sleep after I'd been into a few second stage rooms and saw the way women were treated. I don't have the time to talk to you about it now, but it was profoundly life-changing to me. And then I visited women living in refugee camps in Athens with Doctors of the World, and I wrote an article called Being Born Without a Home. So these women actually have lovely care in the camps because the Midwives Association, the Greek Midwives Association, have developed midwifery, and there are volunteers who go over. So in pregnancy they have wonderful care, but when they go into hospital, it's a very medicalized system. They don't have an interpreter, they can't take a family member with them, they don't have adequate pain relief. The cesarean section rate is very, very high indeed. And these are women actually who need the most humanized care possible. The Greek midwives would like to provide care outside of a hospital, but the Obstetric Association won't let them do that. The women I met were so dignified, they were so proud, they were so courageous. And this is a woman who invited us into her home, which was a container, and gave us tea. And I was with Baroness Sheehan, and she could speak Arabic, and she actually translated for me. And I said to her, "What is it you most want for your family?" And she said, "All we want is safety for our family. All we want is respect and safety for our family." And these are people who are stuck in Greece. They're not moving on. It's a hugely political problem. So I talked earlier about the microbiome, about the hormones of closeness. Do any of you know about Kirsten Uvnes-Moberg's work? Great, it's really important. So Kirsten Uvnes-Moberg talks about oxytocin, the hormone of love and attachment, of closeness, of relationship, and her books are very, very readable. And the microbiome, of course, is very important. The way we're born will seed the microbiome, affects our immune system, and we think that this is why babies born by cesarean section are more likely to have health problems in later life, because their immune system hasn't been seeded. And Hannah Darlan, Professor of Midwifery, talks about the impact on epigenetics of the way we're born. I'm not going to go into this. This is more work of Jane Sandal's, but she gives, if you want to look at this, the Journal of Physiology, they have a great model about why the way you are born impacts on our health in future life. And so what can we do about it? Well, a really important aspect of the humanization of birth is the development of continuity of carer. It's not all that we need to do, but it's a really important aspect, a piece of the puzzle, if you like. And this is Sadie Holland, and she's in a group practice around King's College Hospital in London. And this slide was given to me by Sadie, who got permission from the family, who is shown here. So being with woman is what we're aiming for in continuity of carer. And this is Jane and John, and I was midwife to 5 of Jane's children. And I've just been to the second wedding 2 Saturdays ago. I was at the wedding of one of my babies. And her birth was written about in the new midwifery. This is real continuity. At the wedding, I kept looking at this beautiful bride, thinking, I was actually the first person to touch you. So I'm going to be talking very briefly about continuity of carer, because I want to have some time for discussion. And the first thing that I want to say is, when we're talking about continuity of carer, we're talking about the formation of a relationship of trust, of knowing each other over time, that's developed over time. And we're talking about systems of care that allow the formation of that relationship over time, but also recognizes that midwives have another life, that they have to have time off, that work needs to meet their needs as well, balancing these two. And much of what I'm talking about comes from a report that was written after a scientific study group that I curated in Green Templeton College in Oxford. And Jane Sandal was part of it, and she actually helped lead the writing and editing of the report that came from that. And this was a symposium group that was held just before the publication of Better Births in England. And we had Julia Cumberledge involved in one day of it. And it was a truly multidisciplinary group. And the money came from Sheila Kitzinger's family, who set up a series of seminars at Oxford University, Green Templeton College, in Sheila's memory. How many of you know Sheila Kitzinger and her work? So many of you know her. So Sheila was a wonderful writer, close friend of mine, and she, I think, was probably the person that we have to thank for our idea of woman-centred care. But we had commissioners, we had health implementation scientists, we had 3 obstetricians who were very, very good in this group, heads of midwifery, and all sorts of people involved. Mary Ross Davey was there, Rebecca Schiller. And this is the group in Oxford where it's always sunny and warm. In a break, we had an evening and 2 days, and then the writing of the report. And the aim of this group was to help promote understanding of how we might, within the NHS, implement the evidence and scale up and sustain relational continuity and highlighting gaps in the evidence. And it was actually the obstetricians who, when they heard the evidence, said, this is absolutely compelling. It would be unethical not to implement it. And what we began to realize, and it sounds very, very obvious to you, is that continuity of carer is essential for safety of the services as well as high quality services. It isn't a nice add-on, it's absolutely fundamental to safe care. And the way we described the problem is this, that birth in the UK is generally very safe for the majority of women and their babies. That's from the King's Fund report. But problems in maternity care persist, and we know that these problems disproportionately affect women and babies from some ethnic groups and those who are socio-economically disadvantaged. And we redescribed safe and high quality care. It's care that leads to healthy physical and psychological outcomes, supports family relationships, and reduces the impact of inequalities. It requires models that meet each individual woman and her baby's health, personal and social needs and preferences. And safety is increased by understanding and reinforcing the ability to bridge gaps and discontinuities in care, reducing variations in outcomes. And any of you who are interested in epidemiology, public health, will know that there are huge variations in outcomes between services, both mortality and morbidity rates and intervention rates. And when we try to improve quality of care, we're trying to reduce those variations. But also there are huge gaps in services, and it's often the more vulnerable women who fall through those gaps in the services, where problems aren't picked up, where there isn't follow-on, and so on. And actually having a named midwife or a named doctor that the woman gets to know over a time, working in a group so that somebody is following that woman up, making sure she knows the results of tests, that she's referred appropriately, and so on, is really, really important. We almost call this report Mind the Gap, Mind the Gaps. Because if any of you have been into the health service for treatment recently, you will know it's extremely complicated. My husband has Parkinson's, and I can negotiate health services. I've worked in health services around the world. I can tell you, trying to get an appointment in a timely way is extremely difficult, and you have to be extremely persistent. And so often it's educated, middle class people who can manage that, but women with chaotic lives who don't have the time to think about it, who might come from a different country, it's much more difficult for them. So we started with this statement from the White Ribbon Alliance about the importance of pregnancy and birth and the emphasis on relationship. A woman's relationship with her maternity providers is vitally important. Not only are these encounters a vehicle for essential life-saving health services, but women's experiences with caregivers can empower and comfort or inflict lasting damage and emotional trauma. And we know that many of the women who suffer post-traumatic stress disorder, for example, or psychological damage after birth, it's often not the treatment itself, it's the way they've been treated by people, including midwives within the service. Women who are pregnant are at a critical period in their lives and they feel a lack of care very acutely, and particularly if that care is disrespectful or abusive, it is very, very damaging indeed. So what do women want? This comes from NHS London: to know and be known by members of the team who will be looking after them during pregnancy, labour and postnatally. Be sure that information is passed on, because we're talking about informational continuity as well as relationship continuity. To see the same midwife or midwives throughout pregnancy, labour and during the early period of life. To have a midwife they know staying with them throughout labour and, sorry about this language, delivering their baby. The woman delivers her baby. And there is a hierarchy of continuity, and this is really important when you're thinking about working in or setting up what I would prefer to call group practice. We often call it caseload midwifery or time midwifery. And relational continuity is at the top of the pyramid. It's like Maslow's hierarchy of needs. So very basically, there should be informational continuity, management continuity. And we know that the independent variable that actually affects the good outcomes of continuity of care is a supportive relationship developed over time between an individual and their care provider, who ensures care, coordination and partnership. This idea of partnership, which came out so strongly from New Zealand, is really important. What is it that makes continuity of work? Because in a moment we'll be looking at the Cochrane review and the good outcomes from continuity of carer. Having an advocate, somebody who speaks up for you, having somebody to navigate complex care, having one clinician to ensure timely decisions are made in your best interests. Just a very simple thing. I've worked in continuity of care in a number of different places. Woman's results come back and she has an abnormal result. You wouldn't just put this into the system. You would make sure that you contacted the woman, told her the results, and that she knew what the next step was, that the referral was appropriate. There are all sorts of examples like that. And I think that what is really important is that we think about the midwife wrapping the woman around in her care, the woman and her family, this known midwife. But that gives access to the whole of the multi-professional team. This isn't about midwives working in silos. And midwives working in continuity of care or group practices could be working with doctors, in women with more complex medical needs, or women with less complex, more straightforward pregnancies, and sometimes with social problems. And you can see here the kind of referrals that might need to be made. Sexual health services, drug and alcohol support, social workers, mental health team. So this midwife or a small group of midwives who wraps the woman around with her care makes sure that she has access to all of the specialist services that are needed. And there's a lot of emphasis at the moment on identification of mental health needs and making sure that women with mental health needs actually are referred appropriately. I love this diagram. So we've talked about the care partnership, that the midwife provides coordination and navigation of care, advocacy, speaking up for. And we think that the mechanism that leads to the better outcomes of continuity of care are trust, giving the women choice in the care, giving the woman control, listening to women. We know, for example, that in situations where women's babies have died, the women will often feel that they weren't listened to by the doctors or the midwives who were looking after them. I knew my baby wasn't moving well enough, or I was worried, but they felt that they weren't listened to. Continuity of care is associated with improved access to care and patient safety. And the midwife or midwives maintain an oversight. So if you think about a woman going into the fragmented system, She actually doesn't have anyone keeping an oversight of her care. These are just such simple ideas. And care remains personalised, and the woman's needs are the key focus for all. So the models are caseload or team midwifery, and I like to think about one-to-one midwifery, which we developed at Queen Charlotte's in the early 1990s, now set up around the Wirral, very successful. And there are simple principles. It can be set up in a number of different ways, but the primary midwife provides wraparound care. And as long as there's fidelity to the principle of relationship-based continuity over time, the approaches may be tailored to local needs. So it might be that you have a hybrid model with midwives on shift. You might have midwives on call. You might have midwives working, for example, with women with diabetes, specialist services. And there are a lot of myths about continuity of care. Where continuity of care is set up well, the risk of burnout is much lower than it is with standard fragmented care. And this is because midwives actually treasure a relationship with women. It makes their work meaningful. Those midwives have to have a high level of personal control over how work is organised. And in one-to-one midwifery at Queen Charlotte's, the midwives worked in group practices of 6 or 8, and they decided how to provide a service 24/7 for a local area in a couple of different postal codes. And it didn't mean that the midwives had to be on call 24/7. So there was one midwife who was a named midwife. She worked with a partner or a buddy, you would call it here in Scotland. And they worked in a group of 6 or 8, making sure that there was always somebody available for women on call. And I talked earlier about women with medically and socially complex pregnancies who might fall through the gaps. And this slide, which actually I got from Leah Briganti, is the outcome of the Cochrane review of midwife-led continuity model versus other models of care. And for the students, do you know what Cochrane reviews are? Yeah, so you know about meta-analysis and metasynthesis and so on. Great, fantastic. When I think about what I knew as a student, I didn't know anything. But then we didn't have Cochrane Library then, did we? So it's small team or case loading versus standard care. And these randomized controlled trials were in Australia, Canada, Ireland, and the UK. There were 15 randomized controlled trials with over 17,000 women between these years, 1989, 2013. And some of the systems looked after women with more straightforward pregnancies, and some had women with more complex and more straightforward pregnancies. And many of you might know this, but women who received models of midwife-led continuity of care were 7 times more likely to be attended at birth by a known midwife, 16% less likely to lose their baby. Now this has come up in the recently published NHS long-term plan. It's right there in the headlines. Theresa May talked about the importance of the start of life, that actually midwife-led continuity of care will reduce fetal loss associated with the reduction of fetal loss. 19% less likely to lose their baby before 24 weeks, 15% less likely to have regional analgesia, 24% less likely to experience preterm birth. Now think about it, think about the human and economic cost of preterm birth. Almost 25% reduction. We don't know quite why that is. We have a number of theories about it. And Jane Sandel and others have set up a trial of women who are at high risk of preterm birth to actually see whether or not continuity of care in this situation will prevent preterm birth and less likely to have an episiotomy. So you'll find that midwives who are randomized to midwife-led care, less likely to have preterm birth, less overall fetal death, fetal loss before 24 weeks. But interestingly, the intervention rates are lower. So they have a lower rate of instrumental vaginal birth, regional analgesia, amniotomy and episiotomy. So you have this combination of a lower rate of intervention and better outcomes. And women's experience was better. They had better information, advice and explanation, could choose their place of birth, preparation for labour and birth, and choice of pain relief and feeling in control. And in summary in that report we said, to date there's little sustainable development of relational continuity in the NHS, but the evidence is now too strong to ignore. And it gives us the opportunity to improve outcomes for those groups who are at higher risk of maternal infant death and morbidity, and who more often experience failures in care. And efforts need now to focus on implementation and scale up. In policy documents in all of the United Kingdom, there's an emphasis on scaling up, developing continuity of care. And I've just written the foreword to this beautiful book. And Susan, your work in that book is absolutely groundbreaking, dealing with the issues of sustainability. And I think we should be asking questions about the sustainability of standard health services at the moment, because they aren't sustainable. We've had the Whelm report showing the problems of midwives working in present-day maternity services. The costs are going up. Most services are working way beyond capacity. But of course, we need to be developing continuity models that are sustainable for health services and for midwives. Now, this book gives the evidence, but also gives examples from New Zealand and Canada. And New Zealand is the only country in the world that has actually developed continuity of care across the whole country. So Susan will stop me if I say it wrong, but women can choose their lead provider. The majority, over 90%, choose a midwife. So midwives look after women who've got more complex pregnancies or more straightforward pregnancies. And it's basically been institutionalized across the whole country. And New Zealand is the only country that's been able to do that. So this book by Caroline Homer, Nikki Lee, Pat Brodie and Jane Sandel will be coming out this year and is really important. And that's a bit about from my forward that I'm not going to be talking about. So moving from that relationship between the midwife and the woman that she's looking after, the woman and her midwife, and it's reciprocal. So it's important that the woman gets to know and trust the midwife or small number of midwives who are looking after her. But it's also important that the midwife gets to know and trust the women that she is looking after. And one of the things that I think we need to be developing is the midwife working in a relationship with the woman that is sensitive to the woman's needs, which models what the baby will need from the mother. So if we look at effective or good enough mothering, what the baby being born, what the child needs, is a caregiver, usually the mother, who is actually sensitive and responds to the needs of that baby. And I think what we've left out of our ideas about birth is that this relationship, particularly between the mother and the baby and the father or other parent, and the integrity of the family, is absolutely critical to the long-term physical health, survival, and emotional health of that baby. What they learn from those relationships serves as a template to all other relationships in life. You can overcome problems at that period, but it's much easier not to have those problems in the first place. Susan?
Yeah, 5 minutes.
5 minutes. I thought you were going to make a point. So these affiliative bonds should be one of our aims. So the primary role of love for survival, safety and well-being of the young is absolutely critical. And care around birth makes a critical contribution to this bond. And we often disturb the physiological basis of that bond. The oxytocin that I talked about earlier, the prolactin, the stress of birth. The oxytocin is at its highest during labor, birth, breastfeeding. So we can disturb that process by over-intervention, by creating fear, and we can actually support it by reducing unnecessary intervention, but if intervention is required, supporting the physiology in other ways, for example, skin to skin after a cesarean section. So thinking about what we're doing to that bond is absolutely critical. So we're thinking about supporting a secure attachment, which is essential to survival and well-being of the baby into adulthood. And support physiology is important to the health and well-being of the mother and baby. And Dr. Sarah Buckley's work is really important and gives a very good description of that. And she gives another number of recommendations which are actually helped by the policy that we have in the United Kingdom. And if we implement that policy, we will actually support the physiology and will support a secure bond of love between the baby and mother and caregivers. Our policies are amongst the best in the world. We simply have to implement them. And it's not very simple. Because it's a change of paradigm. We have the Lancet series from Mary Renfrew and team, which actually gives us a very broad framework. And if we implement this framework, we will have humanized care. And Sue Down has shown that what women want and need to achieve is a positive pregnancy and birth experience, support, relevant and timely information, clinical care and therapeutic practices. It's both safety and well-being, and hermetosynthesis is really important to us. I'm going to get to the end here. We know that midwives feel frustrated wherever they practice around the world. They feel that they're not able to fulfill their role completely. So working on that is really important, whether they're in high income, middle income, or low income countries. And what we need to remember is that when we attend women when they give birth to their baby, is that we're actually being part of a story. We will help create the woman's story about the birth of her baby and how she felt about it. And I love this slide, which was given to me by Leah Millenship, a photographer who spent a few days in a labour ward taking pictures that actually showed the humanity around birth. And here is a grandmother who'd popped out to have a cup of tea, and when she got back, the baby had been born. Look at her face, but look at the eye contact between the mother and the baby and the father, and the tenderness in that picture. It's absolutely beautiful. So what I want to do is to ask each one of you after today to think about one thing that will help you humanize birth, make your care more humane. And it's particularly important for the students because you're just starting out, you're just developing your ideas. And I can't finish this session without talking about spirituality in childbirth. So I wrote the foreword to this book, Susan Crowther and Jenny Hall, and it is absolutely beautiful. It isn't one of those soft and fuzzy books. It isn't all about normal birth. It takes a really, really deep look at the meaning of birth and the spirituality. I can't speak for you, Susan, but is much wider than just a religious spirituality. And I just loved this book, and it kind of illuminated things for me. And there was one chapter about the crowning of the baby's head. And I suddenly thought about this term crowning, the baby being born and the crowning, like a king or a queen being crowned. And it suddenly occurred to me that halos in religious pictures might be about the crowning at the moment of birth. But anyway, this book, I think, just brings something into our knowledge which was lacking before. And I just want to pay tribute, Susan, to the work that you've done, because Susan is somebody who's had extensive practical experience in New Zealand and here, but who is an academic who thinks very widely. And this book is beautifully edited, beautifully written. And I think that there's probably nothing better than this book to represent the deep meaning and the reverence you obviously have for midwifery and midwives, and the enthusiasm and importance with which you hold midwifery and the education of midwives. I want to thank you for all the work that you've done. So the birth of the baby is the birth of our world and our future humanity. And achievement. NHS long-term plan published a couple of days ago on the day that the House of Commons started their discussion on Brexit. But actually it mentioned continuity of carer teams are being developed and launched across the country with the aim that in 2019 20% of pregnant women will be offered the opportunity to have the same midwife caring for them throughout their pregnancy, during birth and postnatally, and it gives a lot of description. So in this whole NHS long-term plan, and it was top of the news, and Theresa May talked about the importance of birth. So yes, we can feel frustrated, but we've actually come a long way in many ways. And my favourite picture with the King's College London first year students, they're all now well qualified and working in different parts of the world. And we did a bike ride around London, around the Serpentine, and we landed on College Green. All the interviews about Brexit at the moment are on College Green. It's pouring of rain. We took cake, we handed it to passers-by and members of Parliament, and a little card about why we needed more midwives. And I took my Pashley bike on the train from Oxford to London and then rode all around London in this pouring rain. And this was totally organised by the first year midwifery students at King's College London. It probably got more attention than any other kind of PR work in the Royal College of Midwives at that time. So you can see here that I just love midwifery. I love being a midwife. I wish I was a student in my second year, starting out again. And it's been such a pleasure. I hope it's made some sense to you. I feel as if I've covered so many different areas.